am Dr. Kakoli Lahkar. I am a consultant in medical oncology in Manipal Hospital, Old Airport Road, Bangalore. On behalf of Manipal Hospitals, Bangalore, I welcome you all to today's panel discussion. On November 7th is celebrated as National Cancer Awareness Day, and on this occasion, we want to present to you a discussion on the therapeutic developments in the field of cancer management. Cancer is the second most common cause of death globally after cardiovascular diseases. In India, the incidence of cancer is around 100 per 1 lakh population per year. And the common types of cancers are breast cancer, lung cancer, colorectal cancer, head and neck cancer, stomach cancer, ovarian and cervical cancers. So, in the last 2 decades, the management of cancer has undergone a tremendous pace of development. Unprecedented therapies, personalized treatment, targeted therapy, immunotherapy, modern techniques of radiation therapy, all this have totally changed the management of cancer. So what was once a universally fatal disease has now become a treatable, curable and manageable disease. So as per international statistics, 2 out of 3 cancers can actually be cured. Now how has this become possible? So to discuss this, we have assembled 3 eminent, highly qualified and highly experienced oncologists in Manipal hospitals. To begin with, Dr. Amit Rauthan, he is the HOD and consultant in medical oncology in Manipal hospitals, Bangalore. We have Dr. Poonam Patil, she is a senior consultant in medical oncology in Manipal Comprehensive Cancer Center, Bangalore, and also Dr. Sindhu who is a consultant in radiation oncology, and she will be enlightening us on the various developments in the field of radiotherapy. Now, at the turn of this century, around 2000, there was a blockbuster drug which was discovered, and almost by serendipity. And this drug, which was called as imatinib, it actually targeted a particular gene in a rare type of blood cancer called CML. So, what happened was that, so after this blockbuster drug came into the picture, which could target the particular mutation in a cancer which drove this cancer, it caused a paradigm shift in the management of cancer. So this drug, which was called as a magic bullet or targeted therapy, this ushered in an era of individualized treatment, gene targeted therapy, immunotherapy, and the armamentarium of cancer treatment has just progressed from there on. So the first question would be to Dr. Poonam Patil. So what exactly is targeted therapy and what are the different types of targeted therapy?
So as you said rightly that how imatinib was discovered, you know that all the cells, normal as well as abnormal, they thrive based on their genes, the proteins the genes make, and that is what is made use of in cancer cells as well. And if we can identify a target that is an abnormal gene or an abnormal protein that is made by the cancer cell, and if a drug is available in the armamentarium of treating cancers, we can make use of the drugs to treat that particular cancer. Now what these drugs do, they can either stop the gene from functioning, or they can block the protein synthesis, or they can stop feeding the tumor by inhibiting new blood vessel formation, or they can trigger the immune system to kill the cells, or like hormone therapy which is used for breast cancers. So there are various ways in which these targeted treatments could be used in treatment of cancer, and that is the basis of personalized medicine or precision medicine, that you identify a target and then there is a medicine against that target.
And the interesting thing about this is that most of these are tablets, right? The targeted therapy, people can just pop a pill a day and they can live a long healthy life. So in biological therapy, now when we talk about targeted therapy, the question of biological therapy also comes in. So is biological therapy the same, or is it?
So biological therapy is also known as biological response modifiers, which we club as biological therapy. They are also targeted therapies, but most of the times they are given intravenously, and a slight difference between the two terms, targeted therapy and biological therapy. Biological therapies are targeted therapies, but all targeted therapies are not biological therapies. As I said, biological therapies most of the times are monoclonal antibodies which are given intravenously.
I think the public would know about monoclonal antibody now because of COVID and the way we used it, but it actually we started using it much before that in cancer and in rheumatological disorders. Now coming to immunotherapy, so that is the buzzword in the town. So recently there was an article where almost all patients were cured of colon cancer because of this blockbuster immunotherapy drug. Now, Manipal Comprehensive Cancer Center happens to be one of the leading centers for immunotherapy treatment in the country, not just the city. And heading this unit is Dr. Amit Rauthan. And so, sir, I would like to ask you, what exactly is immunotherapy or immuno-oncology as the broad term denotes?
Immunotherapy is the fascinating new space in cancer management. So for years we have had surgery, chemotherapy, radiation, but there was no new discovery till the targeted and the biological therapies came up. But in the last 6 years, we have these new medications which have come up, which are called immunotherapy drugs. And what are they? They actually unblock our own immune system to fight cancer cells. So that's where they differ from chemotherapy. Chemotherapy is killing cancer cells, but it also kills some amount of normal cells. Immunotherapy unblocks our own immune system, and these activated T cells will go and kill the cancer cells. So this is a very fascinating new space which has come in. What we have seen, immunotherapy, these are injections which are given at regular intervals. They are at present being used in advanced cancers, and if the T cells get activated, they kill the cancer cells, patients get better, and the cancer gets controlled. And why immunotherapy is very fascinating is they can work even with very advanced cancers, but if they respond, they can give a very durable response. And that's why immunotherapy is so fascinating. Stage 4 patients getting potentially cured with immunotherapy in a space where there was no option available for them.
So, when we say immunotherapy, of course, what are the common types of cancer in your regular practice, in your clinical practice, where you would use immunotherapy? What are the common types? Because I just mentioned that the common types of cancer are breast, lung, as per the data.
So earlier, immunotherapy, when it came in 6 years ago, first came in for treatment of melanoma. But slowly the space expanded. It started being used for renal cell carcinoma. Then it came lung carcinoma. And now almost every cancer is being treated with immunotherapy. Be it head and neck cancer, be it lung cancer, be it stomach cancer, be it colon cancer, specific types of colon cancers which are called MMR deficient colon cancers, be it Hodgkin's lymphoma, be it kidney cancer, bladder cancers, even endometrial cancers, cervical cancers. You name the cancer now, immunotherapy is being used in their treatment. So it's something which has come up so rapidly. In the last 5-6 years, it's now getting into dominating the space of cancer management. It does not mean the other treatments are not important. They are all very important, but immunotherapy is now coming up very rapidly for all these cancers.
So basically it is almost now all pervasive. Now it is applicable in almost all cancers, and like sir said, most of the times it is used in advanced cancers, but now they are more and more being used in earlier stages of cancers also. So now the indications are moving towards the earlier stages of cancer, and very soon actually a day may come when we might just do with targeted therapy and immunotherapy and avoid chemotherapy altogether. That day may come in the near future. Now moving on to radiation oncology. So I remember when we were first in medical school, of course all we had was a Cobalt machine and a radiation oncologist who used anatomical landmarks to actually deliver radiotherapy. There was no computerized planning, and then of course LINAC came, and now the development has been unprecedented. It has been tremendous, such newer techniques, such precision in delivering radiotherapy. Now one of the terms which come to my mind is stereotactic body radiotherapy. Now Dr. Sindhu, please tell us what exactly is stereotactic body radiotherapy, where is it used, and how does it actually make a difference? I mean, side effects wise, or the precision wise, how does it actually make a difference?
So the stereotactic body radiotherapy, it's known as SBRT. It is also known as stereotactic ablative radiotherapy, or SART. It's a technological advancement in the field of radiation oncology. So it is different from conventional radiation, because usually in conventional radiation we are delivering a dose of 1.8 to 2 gray per day. It's a very small dose. But in SBRT, we are delivering very high or ablative doses of radiation to extracranial sites like liver, lung, pancreas, and in limited number of fractions. So in most cases, radiation is typically delivered over 1 to 5 fractions, but sometimes up to 10 fractions can be used even in SBRT. So the principle of SBRT is to deliver very high or ablative doses of radiation to cause necrosis or death of the irradiated tissue. So in this SBRT, usually we will be generating a highly sophisticated radiation treatment plan. So it is possible to deliver very high dose of radiation to the tumor, simultaneously sparing the surrounding healthy normal structures from collateral damage. So the damage to the surrounding structures will be negligible, and we can achieve an ablative dose. Since we are giving an ablative dose to the tumor, we can achieve a very good local control with respect to the cancer. And it is a very well tolerated, non-invasive treatment which does not require any hospitalization. That is the advantage or merit of it. It doesn't require hospitalization, or it does not require any sort of complicated preparation. It is a non-invasive treatment also. So the SBRT, with the evolution of SBRT or SART, many tumor sites can be treated. As you asked me, the indications, if you see, it can be broadly categorized as management of primary tumors, as for example in lung cancers, liver, hepatocellular carcinoma, pancreatic cancer, kidney, adrenal gland cancers, as well as in the management of metastatic setting. Patients with oligometastatic disease from any primary tumor sites are good candidates for SBRT. And especially in patients with recurrent tumors like head and neck tumor recurrences or pelvic tumor recurrences, SBRT is one of the attractive and safe options with very good local control and decreased toxicity. So in SBRT, to deliver SBRT, we require some specially designed machines, that linear accelerators and modern immobilization devices, as well as some new imaging technologies. So since in SBRT, the area of exposure of higher dose of radiation is limited, and the dose constraints of the adjacent critical organs are always met, the majority of the patient crowd who undergo SBRT, they tolerate the SBRT without any major side effects. Most of the crowd will do well, they will complete the treatment without any major side effects. Some patients can have some minimal or mild side effects, temporary side effects. They include some fatigue, generalized weakness, that may be lasting over few days after treatment. And if you are treating liver or pancreas, abdominal SBRTs, that can lead to some temporary nausea, vomiting or diarrhea. In the case of lung SBRTs, occasionally some patients can have a bit of dry cough on a temporary basis. And SBRT has led to very good local controls with respect to most of the sites. In the case of lung cancer, if you see, stage 1 non-small cell lung cancer, the local control rates with SBRT, 2-year local control rate of almost 95% and 3-year local control rate of 90%. In the case of liver cancer, local control rates are in the range of almost 80 to 90% 1 year. So that sort of amazing results we can achieve with SBRT.
So when we talk of SBRT, another word that comes to my mind, another technique that comes to my mind is therapeutic radiosurgery. Yes. No, it is not exactly literally a surgery in the sense that there is no physical knife or a scalpel which is used. So would you just tell us what exactly is therapeutic radiosurgery, and will you just take us through the steps, how it is done, what is the procedure which is followed and where it is used vis-a-vis SBRT?
So, as you mentioned correctly, stereotactic radiosurgery is not a surgery in conventional sense because it does not involve an opening or incision, and definitely general anesthesia is not required if the patient is an adult. So, it is a highly precise form of therapeutic radiation to deliver external beam radiation to intracranial targets, especially in single session. So that is the difference between SBRT and SRS, because SBRT is mainly meant for extracranial sites, SRS is meant for intracranial sites. So the same SRS, instead of delivering the radiation dose over single fraction, if the same radiation dose is split into several smaller doses, and if it is delivered over 2 to 5 fractions, it is known as a fractionated SRS or staged radiosurgery. So if the tumor size is usually small, less than 3 cm, we will be moving forward with SRS. And if the tumor is situated away from the critical organs, we will be forwarding with a single fraction SRS treatment. But if the tumor is very close to critical organs or eloquent areas in the brain, and if the tumor size is something between more than 3 or less than 5, borderline tumors, we will be going ahead with fractionated SRS or staged radiosurgeries. So when coming to the steps, first and most important step is to immobilize the patient. Yes, olden days we were using rigid head frames for immobilization. So the problem was it was partially invasive procedure because these head frames, they have to be fixed to the patient's head by using some pins under local anesthesia. But nowadays we are doing frameless radiosurgeries. We are not using these invasive frames anymore. So frameless radiosurgeries. So in this frameless radiosurgery, but immobilization has to be done. So the patient's head has to be immobilized by using a regular skull cast or a head cast. So it is absolutely non-invasive. So once the patient's head is immobilized, next step would be to acquire a 3D, three-dimensional image. Either we have to acquire both CT as well as MRI. So these are known as radiation planning CT and radiation planning MRI. Both will be acquired with contrast in the radiation treatment position itself. Once the images are acquired, both of these image sets will be fused. It will be an automatic automatic fusion done by the computer itself, software itself. Once the fusion is done, it is the responsibility of the radiation oncologist to chalk out the tumor as well as the critical organs, nearby critical organs on the MRI series. Once this marking is done, this process is known as delineation or contouring on the MRI set. Once this is done by the radiation oncologist, a highly conformal radiation plan is generated by the dedicated medical physicist. Once this plan is generated, then last and most important step would be the treatment execution or treatment delivery. That means SRS treatment delivery. So with proper image guidance, the radiation treatment will be executed with a sub-millimeter accuracy. So usually in SRS, we will be attaining an accuracy of less than 1 millimeter. So that is the added advantage with SRS. And SRS is most commonly used for many of the brain metastases and many of the primary brain tumors like meningiomas, pituitary tumors, acoustic neuromas, and also for some intracranial conditions like arteriovenous malformations, trigeminal neuralgias, epilepsy. So SRS has emerged as one of the beautiful and most wonderful treatment modality in intracranial tumors.
So actually, thank you, Dr. Sindhu, for so eloquently, clearly, and comprehensively explaining about SBRT and SRS. So we can actually use it also for benign conditions. So like neuralgia and AV malformation. So that is kind of a major boon in the armamentarium of radiotherapy, SRS and SBRT. Now coming back to our discussion on the medical oncology aspects of cancer treatment. So cancer is the very word. It immediately generates fear and anxiety in the minds of people, and it has aptly been called the emperor of all maladies because it was once a universally fatal disease. And it is not just about that it was considered terminal disease. The word cancer generated fear also because of the treatment which a patient had to undergo when he or she is diagnosed with cancer. And especially when people hear the word chemotherapy, all kinds of things come to their mind: hair loss, vomiting, blood counts going down, infections, immunity going down. So this is what has changed actually with the newer treatment options that we have, targeted therapy and immunological therapy. Now I would like to ask Dr. Poonam and Dr. Amit, whether the side effect profile of targeted therapy and immunotherapy, whether they are absolutely side effect free, as people tend to believe sometimes that chemotherapy is the main villain, that is what causes all the all the side effects. Are there any side effects of targeted therapy, madam?
Yes, these targeted therapies, though they look like very small, harmless tablets, they can have side effects starting from head to toe. They can have change of color of hair, there could be sores in the mouth, they can have skin dryness, skin rash, changes in the nails. It can cause changes in the blood pressure, especially high blood pressure, interference with drugs, especially the drugs which prevent blood clotting. It can cause infection and inflammation in the lungs, of the liver. It can cause diarrhea. So there are various side effects that are seen even with these oral drugs, which actually, if you look at it, they really look very small, harmless drugs. But they have varied side effects.
So basically the thing is the side effects are significantly less compared to chemotherapy and maybe less long lasting, and they do not have probably major organ damage effect, but they do come with their own side effects. So similarly, I would like to ask Dr. Amit also, in your experience and in general immunotherapy, whatever the data we have, are there side effects, and if so, what are the side effects and how frequently do you see them?
When we compare immunotherapy with chemotherapy, that's the actual difference. Immuno doesn't kill cells by itself. So that's why you don't have the chemotherapy-induced side effects. So that's a major advantage of immunotherapy. You're not seeing hair fall, you're not seeing vomiting, you're not seeing the low blood counts, you're not seeing infections. So it's much more comfortable using immunotherapy than chemotherapy. But that does not mean there are no side effects to immunotherapy. Immunotherapy unblocks our own immune system. And if our immune system becomes over-unblocked, it can cause what is called as autoimmune reactions in our body. So yes, there may be sometimes mild autoimmune reactions. There may be some skin rashes, there may be some mild diarrhea, there may be some thyroid abnormalities like hypothyroidism. But rarely, if the immune system becomes over-unblocked, it can cause a lot of reactions in the body like pneumonitis, hepatitis, colitis. And it is known that immune system can react against their own body. But the good thing is, the rare side effects or the severe side effects of immunotherapy are seen very rarely. We say normally severe adverse events to immunotherapy are seen only in about 5 to 7% of patients. Most patients would have mild side effects which can be managed. And I think we are seeing that in practice in the last 5 years. We are treating more and more patients with immunotherapy very comfortably, even if they are very elderly. We recently had a patient who was 92 years who was going through immunotherapy successfully and doing very well with no side effects. We are treating many elderly patients. We are taking patients with multiple comorbidities. These are patients who would not have received chemotherapy, would have ended up with palliative care. But now with immunotherapy, we are able to treat them very comfortably. But of course, as oncologists and as treating physicians, we need to know what the side effects are. We need to watch these patients carefully. We need to catch these side effects early and treat them. But if we are doing this well, immunotherapy is a much more safer option than using chemotherapy in many patients.
So basically, the take-home point is that immunotherapy, the side effect-wise, immunotherapy is almost the reverse of chemotherapy in the sense that chemotherapy actually kills the cells in the body and it suppresses the immune system. And immunotherapy, the side effects in chemotherapy arise because of the suppression of the immune system majorly, the major side effects. And in immunotherapy, actually, it's the activation of the immune system. The immune system becomes overactive. It does not recognize sometimes its own cells, and that is the reason why it can actually cause side effects. Even though most of these side effects are manageable, they are temporary, and generally they are not fatal. So, coming to Madam again, so what are the common cancers where you have used targeted therapy? And do you remember a particular case, where you were really impressed, where it was almost like a miracle? Any such case comes to your mind?
Targeted therapies, actually if you go to see, started many years back with the treatment of breast cancers, especially when the tumors were dependent on estrogen and progesterone receptors. And that time there was one tablet known as tamoxifen, which was used for treatment of breast cancers, and that was probably the first targeted therapy that we really knew of. But since then we have many targets identified on cancer cells. There are many drugs which scientists have come up with, and there are still drugs undergoing clinical trials, and breast cancers, lung cancers, colorectal cancers, head and neck cancers, pancreatic cancers, ovarian cancers, uterine cancers, you name it, and there's a targeted therapy available for almost all the cancers that are seen in the body.
Dr. Amit, can you cite a case? Any case comes to your mind? Like, we know immunotherapy and targeted therapy are drugs which we can even give in the ICU. Patients are so sick and we give those drugs and patients actually, it's almost like a miraculous change. It is. So, Dr. Amit, do you, any such case, of course without disclosing patient identity, any such case comes to your mind where, you're really impressed with the way immunotherapy works?
I think immunotherapy has been such a fascinating change for us in cancer management. I can recollect one of our first initial cases. This was in 2016 when immunotherapy was first launched in the world. And I think this was one of our renal cell cancer patients. he had advanced renal cancer which had spread all over. He had been treated with the standard treatment which we used to use in that time called sunitinib, and he had progressed, ended up in the ICU. Now this patient, I remember in 2016, we gave him the option of palliative care because we knew he didn't have long to survive. His wife told us, I want the best treatment and please go ahead with whatever you think is the best. And I remember that's the time when immunotherapy was not available in India. We actually imported the drug and gave it to him. Dramatic response. In 3 cycles, the whole cancer melted away. He came out of the ICU, he got better. By the time the drug became available in India, by 2017, we completed 1 year of immunotherapy and then we stopped treatment. Even today, 2022, we do his PET scans, he has no sign of disease, he's living a normal life. This is one of a turning point for all of us because we learned that immune system activation can reverse cancers exceptionally in certain patients, and this patient was our turning point. He really taught us that immunotherapy can really make a difference in cancer patients, and I still think after that we have had a group of patients who have responded in this manner. Elderly patient, we had a 90-year-old gentleman whom we treated 4 years ago for lung cancer. 4 years down the line, there's no evidence of cancer. He's leading a normal life. And that's why I keep saying that, we are fascinated with immunotherapy and how it can make changes in the life of many cancer patients. Unfortunately, we still don't have a biomarker to say which patient will respond, which patient won't respond. So that's the whole problem with immunotherapy. But yes, where it works, it can show really dramatic responses and very impressive responses. And we have seen that in our patients.
Right, so basically, the moonshot for cancer care is probably here. It's probably here, the moonshot. The thing about immunotherapy and targeted therapy is that, side effects are minimum. But what exactly is the downside? Is cost an issue, sir? I mean, it's the financial aspect of it, both Dr. Poonam and Dr. Amit, the financial aspect of it. And of course, for the targeted therapy, there are some drugs which have been in market for a very long time and we have generics now. But most of the immunotherapy drugs are actually patented and we do not have a generic version. So
yes, I feel correct. That's the whole problem with cancer care. But if you remember, when cancer care started, even the new chemotherapy drugs used to be very expensive. Then the targeted and biological therapies came, they used to be very expensive. Immunotherapy, yes, is very expensive, no doubt about it. But as years go by, as the whole support programs change, the cost does come down. And what we have seen is the cost is slowly coming down. And as new drugs keep coming into the market, there are new and newer immunotherapy drugs coming into the market as new companies are launching their drugs. I'm sure the cost will keep coming down. Yes, expense plays a major part in cancer treatment and that is a limitation, there's no doubt about it. But we have seen the other side. We have treated more than hundreds of patients in the last few years, though we used to say it's a very expensive drug. But what we are learning is, if you can get a response which can be long-lasting, many patients are committed to their treatment. So I feel, yes, the limitation is cost, no doubt about it, and this is somewhere where we as a medical community have to kind of garner more attention to it so that even the governing bodies can bring down the cost, the drug companies can bring down the cost, and more of our patients can access immunotherapies. That's what we look for. So if you ask me limitations, 2 major limitations. One is cost, and cost is always a limitation in cancer care in India. And the second limitation is biomarkers. We still don't have biomarkers. We are looking for more and more biomarkers so we can choose the right patient where immunotherapy will work and give us the durable response so that the remaining patients, we don't have to treat them and spend that extra money on immunotherapy.
So biomarker means exactly the test or a particular mutation or a particular a particular profile in the tumor or in the patient which will actually tell us how well the particular drug will work, whether it will work or not. So that is what a biomarker is. And like Dr. Amit has highlighted, that it is totally worth the cost. Yes, the cost is high and it will come down in the future sooner or later, but the cost benefit ratio, when we look at that, in medicine, most of the things are about risk benefit ratio and cost benefit ratio, and immunotherapy wins on both counts. And I think Madam would agree that it is the same with targeted therapy.
Yes, you were asking me about a case which we have seen good responses.
Yes.
Now there are so many cases actually. As you said that this chronic myeloid leukemia, where the first drug imatinib, which came out as magic bullet, We have patients who have been put on these tablets for last 20 years, and before this tablet came in, they were on various drugs, maybe for 6 months, maybe for a year, and somehow when this drug came in the market, they were put on these tablets and they're still doing well. So most of them are still doing well. That's more than 20 years for a disease, chronic myeloid leukemia, which was otherwise incurable without a bone marrow transplant. Now they are just taking one tablet a day and they are doing well for the past 20 years. Similarly, in other cancers as well. Breast cancers, the success of hormone therapies is well known, but there's another drug known as trastuzumab, which is used for HER2/neu, the oncogene, if it is found on the breast cancer cell. There's this drug trastuzumab, which came out about, I think, maybe 18 years back or 20 years back. And there are patients who have been on trastuzumab who had extensive metastatic disease, and with this drug they have been doing well. I have one of my patients who's been on trastuzumab for the last 9 years now, who had extensive metastatic disease and is still doing well and is still continuing to take that medicine.
So basically, disease, blood cancer, nonetheless, which actually was fatal in probably 5 years without the transplant, has become something like a diabetes or a hypertension. You just take a pill a day and you live for years, you live for decades, and with very minimum side effects. So that's the pace of development which has happened. That's the kind of era we are living in. And like Dr. Amit has mentioned, that in immunotherapy he mentioned advanced cancers which are potentially cured, which have not come back after using. When I said the statistics of 2 out of 3 cancers are curable, I basically meant the early cancers. Early cancers are highly curable, but now we are actually talking about curing advanced cancers. So that is where we are going. Now, again, coming back to Dr. Sindhu, there is one more thing which I would really like to know from her, and this is about the proton therapy. So there's a lot of buzz about proton therapy, almost everybody wants to know. So what exactly is proton therapy? And is it really used everywhere, or there are specific indications? And again, is it available easily? And is it worth the cost? Because we know that proton therapy is highly costly. So is it again worth the cost?
So proton therapy is one of the advanced form of external beam radiation. So in that we use small charged particles called protons. So proton has some therapeutic benefit over X-rays or gamma rays with respect to the treatment. So to understand this therapeutic gain or benefit, we should understand a bit of radiobiology. So protons are definitely, they are excellent cell killers, but the way by which they deposit or deliver their energy is little different from X-rays and gamma rays. So protons induce less damage to the adjacent healthy structures or tissues when compared to X-rays and gamma rays. Due to this, we can always deliver higher doses of radiation to the tumor or target with higher doses of radiation to the tumor without affecting the surrounding healthy cells. So when coming to this therapeutic benefit of protons, it is highly precise around the target with very minimal or negligible exit dose. So overall, the treatment related side effects, toxicity will be negligible, very much less. So the patient will be able to tolerate or complete the treatment in a better way. So the quality of life will be better during and after the treatment with protons. So proton is most beneficial in some selected category of patients. One is obviously in pediatric population, and second one in a case of re-radiation setting. Patient already has received radiation, now again maybe second time or third time radiations, especially in head and necks and pelvic patients. Proton is a good option. And patients in those areas of tumor where the critical structures are situated in close proximity, definitely proton is much better than X-rays. And patients with some inherent conditions which make them more predisposed to radiation related toxicity or carcinogenesis. Those category of patients also, proton can be a standard of care when compared to X-rays or gamma rays. So if you ask me the indications of protons, yes, proton is the preferred treatment for many of the cancers. The most common ones are, one is ocular tumors, especially in ocular melanomas, and base of skull tumors like chordomas or chondrosarcomas. In case of recurrent tumors, especially in head and necks, pediatric solid tumors, and retroperitoneal sarcomas, where because of the close proximity to the bowel, the radiation to higher doses is always a problem. So, retroperitoneal sarcomas and hepatocellular carcinomas and brain and spinal cord, any benign or malignant tumors, all these can be considered as good indications for proton. But proton, as of now in India, it is available only in Apollo Proton Cancer Center in Chennai, and the cost of the treatment will be nearly 30 to 35 lakhs for the entire treatment. So obviously it is an expensive treatment. So we have to really carefully choose or select the patient population who require that proton treatment. For example, any pediatric population, because of the chances of secondary cancers or carcinogenesis, because of that fact we can always consider pediatric population, or in the setting of radiation, we can always consider these patients for proton therapy. So as of now in India only it is available in Chennai, APCC, Apollo Proton Cancer Center. Across the world more than 100 proton cancer centers are there. In India, TMH is under the commissioning for proton. Most likely by next year it will come into the full function.
Thank you again for succinctly describing about proton therapy. The selection is the key. So we have to select the right patients because it is pretty expensive and it is not easily available or accessible to everyone. So basically selecting the correct patient is basically the key to treatment with proton therapy. Now, Dr. Poonam has been practicing oncology for more than 2 decades, for almost 25 years. So, I think she is very well placed to tell us that how cancer management has changed over the years and how targeted therapy or immunotherapy has actually changed cancer management and what difference she feels when she was practicing way back in 1999 and now in 2002.
Yeah, so there has been a paradigm shift in cancer management as such. It's not just in chemotherapy, it's in all the fields, surgery, radiation, chemotherapy, and even in chemotherapy, not just the chemotherapy, immunotherapy, targeted therapies. Now we have come to the era of precision medicine or personalized medicine. All these things have totally changed the landscape, and also our understanding of cancer has become much more clear, but still cancer though remains a little evasive disease. But we know much more about cancers and their management than we knew about 20-25 years back.
Yeah. Dr. Amit, your few words on immunotherapy just to sum it up. And overall, the changes you have experienced, in treating cancer over the years.
What I would say is, we were using chemotherapy. We were medical oncologists. We were always called chemotherapy doctors. And that's what we used to do for many, many years. And we have seen the side effects of chemo. And I kind of, as time changed, our understanding of the biology of cancer changed and genomics came into the picture. And with doing testing for tumor for what is called as next generation sequencing, we started understanding pathways for cancer. And then molecular therapies and biological therapies came. Now that changed cancer management. We started having oral tablets, we added targeted therapies. And now immunotherapy has come in, where we have understood how our immune system is controlling cancer. And with this, we have changed. What we see is we have improved quality of life of patients. There's absolutely no doubt about people living now with cancer have a much better quality of life because of these advanced therapies, because of better supportive care of what we do. And we are improving the duration of survival. Stage 4 patients having longer survival. Of course, a stage 4 patient, we wouldn't easily use the word cure for stage 4. We say potential to cure a stage 4 patient is there. But yes, as we are moving immunotherapy into more and more lines of therapy, our patients are living much longer with a better quality of life. So we kind of keep telling patients, don't lose out hope. There may be potential for better therapies available. We have to try and find out these newer options and try to give a hope for a better survival even in advanced cancer.
Basically the word which we are all trying to say is personalized medicine. So from one size fits all to it has come to bespoke tailoring, actually, so to say, of patient treatment to the individual patient based on the genomic profile of the patient, based on the genomic profile of the tumor. So a day will come when the treatment will be actually customized to each and every patient maybe. So that day is not very far. And so after the discussion today regarding the therapeutic developments in the field of cancer, We have realized, I hope, that cancer is a treatable disease. It is a curable disease, even in advanced stages. If it is not absolutely curable, even then, the quality and the quantity both can be significantly improved with the newer treatment techniques. Radiation oncology has become very, very precise and accurate and very, very organ sparing. And when we say medical oncology, we are not just chemo doctors anymore. So we do hormonal therapy, targeted therapy, biological therapy, immunotherapy, and gene targeted therapy. So all these are medical oncology now, and all these will go a long way in treating, curing, and managing cancer patients. So ultimately, what I would like to say is probably the invincible, the indomitable human spirit will someday manage to conquer the emperor of all maladies, which is cancer. Stay safe, stay healthy.